All right, so thank you to Jenna and Stacy for inviting me. I've been assigned the pro side of this argument. I have no financial disclosures, so given that it is my job to convince you to image, although you seem to already want to do that, I'd like to unofficially retitle this talk from Do All Children with Acute Comitant Esotropia, what I'm going to call ACE, require neuroimaging, to Don't Be the Doctor Who Misses a Brain Tumor in a Kid. Now, I'm not telling you that you have to image every kid with esotropia who walks through your door. That would be insane. First of all, take out all the incompetent kids, because you're likely going to image a lot of them anyway. And then among the competent ones, if they fit perfectly for your classic infantile or accommodative ET, and I'll even concede that if you have a kid with acute comitant esotropia who comes in with a clear history of monocular occlusion preceding, like they dressed up as a pirate for Halloween, you don't have to image those kids. It's the other ones that don't fit into any of those categories that you might miss a brain tumor if you don't scan. Now, if you have any conception that competency is protective against neurologic badness, that's just not correct. We've known for a long time now that you can have a comitant deviation and a brain tumor. This study from the great folks at CHOP was a retrospective review that looked at kids with acquired ET with known neurologic pathology, and 40% of them had comitant deviations. Interestingly, half of those they didn't detect a sixth nerve palsy in, and it just speaks to the fact that the mechanism of ET in these kids is not exactly only sixth nerve palsy. There's some central interruption of vergence and some other things we don't fully understand. And there can be significant badness, mostly posterior fossa tumors, but other things that you really don't want to miss. And while there are series out there that show kids with no tumors when they were followed, there are also ones that show upwards of 10% of kids in series having intracranial things that you don't want to miss. Wouldn't it be nice if there were risk factors that we could screen for in these kids to know how to stratify which ones to image and which ones not to? Well, there's a study that looked at that, and they found there were, in fact, some risk factors that increase the likelihood of intracranial disease. The problem is that even within this series, there were kids with none of these. So if you had based your decision to image or not just on whether or not these factors were present, you would have missed some. So I went ahead and did a literature search, and this is not even comprehensive. I looked not just for cases of ACE with intracranial pathology, because those are plentiful, but I looked specifically for those cases of ACE with intracranial pathology that had no other neurologic signs. You could see the font is very small, because there were lots of them. They wouldn't fit on the slide, there were so many. And I will argue that even when there are neurologic signs present, they can be subtle. Now, how many of you out there feel 100% confident that you're not going to miss a very mild papilledema or a subtle sixth nerve palsy in a wiggly kid? And also, as has already been stated by some of our other great panelists, kids are not great historians. They're not going to tell you that they're having pulsatile tinnitus or positional headaches. Now, I imagine the two main arguments against imaging these kids are going to be resource utilization and safety. As far as resource utilization, there are not that many of these kids. You're not going to see them every day or every week or maybe even every month. And as far as safety, I cite this study that looked at whether or not MRI in kids met the minimal risk standard for research studies, for healthy kids. They looked at risk of injury or death from MRI compared to things like playing regular sports or taking a car trip. And they found that, this is not a typo, per 100,000 hours of ice hockey, there were 12,730 injuries in kids, compared to 17 from MRI, and these were mild. And as far as death, the risk from MRI was lower than the risk of a car trip, especially if your kid is in the age to have a learning permit. So the two takeaways that I gained from this study are that one, MRI, basic MRI, meets the minimal risk standard for healthy kids. So if you think a kid might have a brain tumor, I would say it definitely meets the standard. And two, I will never let my kids play ice hockey. Now, you may say, what about sedation? What about contrast? And yes, those do increase risk. Some of these kids are going to be old enough that they're not going to require sedation. These are older than your typical accommodative ETs or infantile ETs, of course. And the risk of contrast is a real thing, but many of these, where I trained at Boston Children's, you do a scan without contrast first, and then you add contrast if there's something that's of concern. So in summary, ACE is rare. It can be the sole presenting sign in a child with serious intracranial pathology. Even when there are other signs, they can be subtle, and a basic MRI is safer than the drive to the scanner. If you find pathology in every single MRI scan you order, you are probably not ordering enough. So do all children with acute comitant esotropia require neuroimaging? Yes. Don't be the doctor who misses a brain tumor in a kid.